learning program in pediatric cardiology for the pediatricians. And today the topic is outflow tract obstruction. This is aortic stenosis, pulmonary stenosis, and speaker is no other than Madam Professor Anita Saxena. She is retired head of department from AIMS and now executive director at the Escorts Fortis Heart Institute. Ma'am doesn't need any introduction. She had sort of the pioneer in field of pediatric cardiology in India and mentor to all of us. Actually, we just learning from ma'am always. The panelist here is Dr. Saad. Saad is professor at Aligarh Medical University and our dear colleague doing wonderful job under the RBSK program for the needy person in Uttar Pradesh. So I welcome Saad to be here, and I request ma'am to start her presentation.
Okay, thank you, Dr. Manish, for those nice, kind words. Also, thanks to Dr. Shad and others who are here. The topic that we are going to discuss today is left and right outflow tract obstructions. And Dr. Manish was also keen that I covered coarctation. So we'll go stepwise, and it will be probably good if Dr. Manish agrees that we sort of break down in between and have some discussion as I finish one lesion rather than going on and on.
Yes, ma'am.
Okay, all right. So I'm going to start with this particular case, which is a commonly seen case in an OPD. You have an 8-year-old boy presenting with dyspnea, angina on exertion for last 6 months, was asymptomatic before that, and was discovered to have a heart murmur and was told that he has a heart disease at 1 year of age. Examination was very typical of aortic stenosis, no cardiomegaly, normal first heart sound, narrow or reverse splitting of the second heart sound, good murmur about grade 3/6 and an ejection click. So I think this is a very typical case that you're going to see, and if you examine properly, then you will be able to get all these findings. So what could be the diagnosis? Yes, it is an obstructive lesion for sure. What are the congenital obstructive lesion? That's something we're going to discuss. And how do you sort of take care of such patients? How do you suspect? How do you diagnose? And how do you manage? That is what is important also. Now, if we take outflow tract obstructions, we could probably divide them into the left side and the right side. But basically, it means that there is an obstruction to flow to one of the valves. And it could be arteries, it could be veins. But most often when we say outflow tract obstructions, usually we talk of aortic stenosis or pulmonary stenosis. You can have mitral stenosis, which is congenital, but that's something I'm not going to talk about. That's an inflow obstruction, and that's often rheumatic. You can have varying degree of obstruction severity, and that is how the management is also important, because it depends how severe the obstruction is as to how to manage. Patients may be totally asymptomatic even when the obstruction is severe, but often they would have some symptoms like breathlessness on exertion or even chest pain in case of aortic stenosis. And characteristic finding of right and left outflow tract obstruction, of course, excluding coarctation of aorta, are ejection systolic murmurs. And we call them ejection because it is happening because of the blood being ejected from the outflow into the great artery, aorta or pulmonary artery, and that is why we call them ejection systolic murmur. And if the obstruction is at a valve level, that is aortic valvular stenosis or pulmonary valvular stenosis, we are going to hear a click or an opening sound of the valve. So common conditions, pulmonary stenosis, aortic stenosis, coarctation. And for pulmonary stenosis and aortic stenosis, we should also remember, although valvular is the commonest lesion, but you can have obstruction at the subvalvular or even supravalvular level, which is the least common. So how do we differentiate between the two? Both will have ejection systolic murmur, but in valvular aortic stenosis, the severer the stenosis, later is the peak of the murmur. When I say ejection systolic murmur, what I mean is like a diamond-shaped murmur, which starts after the first heart sound and stops before the second heart sound. And it has a peak in the middle or late. In case of AS, the severe the aortic stenosis, later is the peak. So when you are describing a patient with ejection systolic murmur, it is good to talk about the peaking of that murmur. Is it late or is it early? Then site of the murmur is often in the second right intercostal space for valvular AS, but it could also be in the third left intercostal space, which is also called second aortic area. And in pulmonary stenosis, expected to be in the second left intercostal space. The ejection click is constant. That means it is present in both inspiration and expiration, whereas in valvular PS, you may hear it better on expiration as compared to inspiration. And therefore, it is inconstant. In fact, it is only right-sided event, which is better during expiration. Second heart sound split can give you a fair idea of what lesion are we dealing with. Normally, it is A2, P2. That means first is A2 and then is P2. And the split is not heard during expiration. In normal individuals, it is heard better on inspiration. In case of valvular stenosis, this split can, valvular aortic stenosis, this split can be narrow. And in fact, if it is severe aortic stenosis, you may even have a reverse split. That means A2 coming before P2 and heard better on expiration and less on inspiration. And A2 is generally very well heard in valvular AS, especially when you are dealing with children, which do not usually have a calcific aortic stenosis. Therefore, A2 is normally heard. Why I am emphasizing it? Because in case of pulmonary stenosis, P2 becomes softer. And often the second heart sound is going to be wide and variable because P2 is delayed. Obviously, you will have a left ventricular apex, which is heaving in AS, and you will have a left parasternal heave, which is sustained in case of valvular pulmonary stenosis. So let's talk about pulmonary stenosis first. As I said, the obstruction can be at the valve level, can be at the infundibular level, as shown in B. It can be above the valve, which is in main pulmonary artery. But often when we say supravalvular, it is actually into one of the branches of pulmonary artery, either right or left, or even sometimes both branches of pulmonary arteries. You can have proximal stenosis at the ostium. You can also have multiple stenosis in the distal branches of pulmonary arteries in some specific syndromic conditions. So supravalvular is often peripheral, very less commonly at the MPA level or main pulmonary artery level. Now, how does it affect the heart? As we expect, right ventricular pressure is going to increase because of pulmonary stenosis. And to maintain forward blood flow, the RV pressure increases, and that produces right ventricle to pulmonary artery gradient, which is what we say pulmonary stenosis gradient. There's obviously right ventricular hypertrophy. The severer the stenosis, it's going to be a delayed pulmonary component. So you're going to have wide variable split of the second heart sound, and P2 becomes soft. Cardiac output remains okay, remains normal, even if the obstruction is severe, as long as the right ventricle is able to pump all the blood into the pulmonary artery, and that happens when the right ventricular function is normal. But at some point, when the obstruction becomes critical, the right ventricle fails, it dilates, and it is not able to cope up with the severe obstruction, and there the cardiac output falls, and therefore pulmonary blood flow also falls, becomes less. So as far as clinical features are concerned, they're often asymptomatic. Even severe stenosis can be asymptomatic, but yes, they can get some fatigue and dyspnea on exertion. Cyanosis is generally not a feature of valvular pulmonary stenosis, but in case there is severe pulmonary stenosis and there is a PFO, patent foramen ovale, or an AST, then you can have right to left shunt across it, and some people like to call it triology of Fallows. And there could be some syndrome associated with this condition, specifically Noonan syndrome, where not only there is pulmonary stenosis, even the valve is abnormal and is often dysplastic. And I'll tell you why it is important to understand that. An examination will reveal a left parasternal heave due to right ventricular hypertrophy, and we did say that there will be a systolic murmur, and of course a click if it is valvular. ECG again is likely to be normal in mild cases. If you're getting right ventricular hypertrophy, right axis deviation, pulmonary stenosis is going to be always severe, because normally you are expected to have normal ventricular forces, right ventricular forces. If there is P pulmonale, that will suggest right atrial enlargement, again indicative of severe case. And of course, if you have right ventricular strain, that will always indicate severe stenosis. So this is an example of severe PS without strain. It is showing right ventricular hypertrophy. It is also showing some amount of P pulmonale, as you can see here. And this is a case where you're getting right ventricular strain pattern. See, look at the STT changes over here. So this is suggestive that there is right ventricular strain pattern, a severe right ventricular hypertrophy. Look at STT changes over here. Obviously, this is suggestive of severe pulmonary stenosis. X-ray chest, normal size heart, as long as right ventricular function is normal. Post-stenotic dilatation of main pulmonary artery segment, normal pulmonary vasculature, unless the patient has gone into failure. Those who have right ventricular failure will show cardiomegaly, and those who have cyanosis will show pulmonary oligemia. Now, pulmonary blood flow remains normal unless right ventricle has failed or ASD shunting right to left. This is, I think, something that we must remember, because we are in the habit of saying pulmonary oligemia and severe PS, which does not happen as long as right ventricle is normal. But if you have cardiomegaly, as shown in this neonatal X-ray, there's actually a neonate, then you know that this is a case of right ventricular dysfunction. So cardiomegaly is not a feature of severe PS unless there is ventricular dysfunction, and that is often associated with tricuspid regurgitation. So if you have cardiomegaly, think about ventricular dysfunction. And the important point is that these patients must undergo an intervention as soon as possible, irrespective of the gradient. In fact, if there is right ventricular dysfunction, your gradients may be actually not high on echocardiography, but still you need to intervene because the right ventricle has failed already. So echo is very, very useful as expected. It not only tells you the severity of obstruction, it also tells you where the obstruction is, how is the right ventricular function, whether there is tricuspid regurgitation or not, and also how to manage this case, how to decide if whether you want to go for balloon, and if balloon, then what kind of balloon, what size of balloon you should use. Normally on echocardiography, we divide pulmonary stenosis into mild, moderate, severe, depending on the peak gradient. Anything more than 40 millimeters of mercury is considered significant because it corresponds to a valve area of less than 0.5. This is an echocardiogram being taken in short axis view, and you can see a lot of turbulence in the main pulmonary artery, and the gradient is quite high, as you can see here, suggestive of severe pulmonary valve stenosis. Treatment, I think it's a relatively easier lesion to treat. If it is valvular pulmonary stenosis, you go ahead and do balloon dilatation, but only in cases which are severe. So gradient of more than 40 is an indication for balloon. If it is less than 40, that means patient has mild or moderate stenosis. There is no need to dilate. You can just follow them up. Most of these patients do not progress. In fact, they would almost show you the same gradient for years together, and there's no need for balloon dilatation in such cases. But if required, it's a very good methodology by which you can almost cure these patients, although you do produce some amount of pulmonary regurgitation, which needs to be followed up. But restenosis is extremely rare. The only exception is dysplastic valve. If the valve is dysplastic, as may happen in Noonan syndrome, then the results of balloon dilatation are not great. You may have to go for repeat balloon, or sometimes even for surgery. So what are the indications for balloon dilatation? Newborns with severe pulmonary stenosis who are duct dependent, obviously you will not go so much by gradient. The very fact that PDA is shunting left to right would mean that PS is severe. And of course, if there is right ventricular dysfunction, then also you require almost an urgent intervention, whatever the gradients are. But in a garden variety of of pulmonary stenosis, elective balloon dilatation can be done if the gradient by echo Doppler is more than 64, even in asymptomatic patients. However, a lot of people have started now doing balloon dilatation for even 40. But if you read the article that we wrote in Indian Pediatrics on timing of intervention, we have still mentioned 64. Remember, if you get gradient of 64 on echo, your CAT gradient is perhaps going to be much less than this, maybe 50, maybe 40. So generally, if the patient is asymptomatic, if the right ventricular function is normal, you would like to wait for a little longer rather than going at 40. But yes, those patients who have hypoxia because of right to left shunt, you may have to go at a lower gradients also. And dysplastic pulmonary valve, you can go ahead and dilate, but as I said, you may have to use a bigger balloon, number one. Number two, they may undergo restenosis over a period of follow-up, and therefore you need to follow them up. As far as subvalvular or supravalvular pulmonary stenosis is concerned, I think the management is little different. Subvalvular is also called infundibular, which is often associated with VST. In fact, it is believed that if there is infundibular stenosis and you are not able to see a VST, then perhaps that VST has closed. Typical example being tetralogy, where you have a large VST with infundibular PS, but isolated infundibular PS is also seen. Obviously, there will not be any click. The murmur may be confused with that of a VST because it is lower down. And of course, you will not have postnodal dilatation on the X-ray chest because there is obstruction, not at the valve level, but below the valve level. If it is severe, then you need to have these patients operated. Otherwise, you can follow them up. Unlike valvular PS, infundibular PS is often progressive and will continue to increase over a period of time, requiring an intervention at some point. Supravalvular, as I said, is often at the level of pulmonary artery bifurcation. There is again no click, and here the pulmonary component is not diminished because main pulmonary artery pressures are actually elevated because obstruction is distal to main pulmonary artery. Murmur may be delayed and is better heard over the back, over the lung fields, and it is often associated with syndromes like Alagille or Williams syndrome. Of course, we also see peripheral PS following surgery for tetralogy or Fallows or any other cyanotic heart disease, but those are really iatrogenic problems and not native. But if you have native bifurcation stenosis or PS stenosis, then you must think about these conditions. These are difficult lesions to treat. Surgeons are also not very, keen on treating them. So what we often do is balloon dilatation, but balloon dilatation alone doesn't really help. So you end up stenting, putting a stent in these patients at the site of stenosis so that the stenosis does not come back. So before I go to aortic stenosis, I would like to take a pause and would invite comments from the panels and then, of course, questions from the students.
I request Saad if there is any question. Yeah.
Yes, ma'am. Majority of good afternoon, ma'am.
Good afternoon.
Ma'am, mostly actually what the concern the patients are that how we have to manage patient, especially neonates with critical PS, because that's one variety which come with failure in first second week of life, and
Right.
they are sicker patients. So little bit on that.
So if it is, yes, I think those are really, critical lesions. And these babies would present with cyanosis, with PDA dependency, and sometimes even right ventricular dysfunction. But also at times the right ventricle is actually very hypertrophic and smallish. It's not really good size. It may be smallish. But yes, all these babies need to be given a chance with balloon dilatation, which is technically quite demanding, quite tricky. And in fact, entering pulmonary artery during balloon dilatation can lead on to complications like perforation. So neonatal pulmonary stenosis is not such a simple lesion like older children, and therefore one has to be ready to treat them in a center where all the hardware and the expertise is available. So these babies are the ones who may require actually repeat balloon dilatations later, because in one go you may not be able to totally take care of the pulmonary stenosis. So this group is little different in the sense that they are sicker, they are cyanotic, their right ventricle may actually be smaller, and they may not have the best results like we have for other balloon dilatation, where you have almost 98% success rates.
Yes. And one of the questions in the chat box is, ma'am, that they're asking whether how the pulmonary blood flow is maintained, like when there is a severe pulmonary stenosis. So I think this is related to, I think, the cardiac output. How is it maintained?
Right.
Yes.
So as long as, and this is true for any obstruction, whether aortic or pulmonary, as long as your ventricle is able to manage by increasing its pressure, by increasing hypertrophy of its muscles, the cardiac output is going to be maintained. So when we say cardiac output is reduced, then you are actually dealing with not severe but critical stenosis. And that is why when cardiac output is reduced or ventricular function goes down, that is the time that forward blood flow reduces. And that is the time where pulmonary blood flow reduces. And that is the time where you have to act rather urgently.
I think, yeah, it's not. No further questions are there, ma'am. So I can continue.
Yes.
Okay, all right. So we'll go on to the next stenotic lesion, outflow tract, which is aortic stenosis. And again, as for pulmonary stenosis, you can have obstruction at the valve level, which is the commonest. And of course, the commonest reason is bicuspid aortic valve, which is rather common. I would say 1% of our population has the bicuspid aortic valve. But in newborns, sometimes it can be unicuspid, which is often inherently stenotic. And therefore, these babies present much earlier. It could be subvalvular, which could be because of a discrete membrane, or it could be muscular narrowing, like you have in fundibular stenosis on the right side, or it could be supravalvular, which is again associated with a specific syndrome called Williams syndrome. So hemodynamics would be the same. The left ventricular systolic pressure has to rise to overcome obstruction. And when there is increase in pressure, obviously there is left ventricular hypertrophy. The ventricle tries to cope up with obstruction as long as it is functioning normally. And there is a delay in the A2 or closure of the valve because the duration of left ventricular systole or ejection gets prolonged because of obstruction. Again, forward cardiac output will be maintained as long as the obstruction is not causing left ventricular failure. So there will be left ventricular stiffness, there will be left ventricular hypertrophy, which will increase its end-diastolic pressure, but the cardiac output will still be maintained. And this left ventricular hypertrophy will also result in an increase in the force of contraction of the left atrium, because left atrium has to push blood into the hypertrophied left ventricle. And of course, if it goes on and we haven't relieved the obstruction, then the left ventricle is going to dilate and fail, which is obviously means very critical stenosis. Clinical features, again, they may be totally asymptomatic, but there are three cardinal features that are described for aortic stenosis if you read in the books: breathlessness, angina on exertion, and syncope. These are three very specific features for aortic stenosis and would always indicate severe obstruction of the aortic valve. Angina obviously is because of relative ischemia of the left ventricle, and syncope, especially which happens on exercise or exertion, are quite indicative of severe stenosis. Pulse becomes low volume with a slow rise, which is typically called pulsus parvus et tardis. Heart size will again remain normal unless the left ventricle has failed, and examination will, besides the typical click and murmur, will give you a left ventricular apex because of hypertrophy of the left ventricle. First heart sound is normal, second heart sound is narrow split, single, or even reversed, as we said, paradoxical. But again, as I mentioned earlier, unlike pulmonary stenosis, aortic component of the second heart sound is not reduced in intensity. So don't expect a soft A2 in AS. In PS, P2 is soft. So as long as the aortic valve is not calcified, A2 is going to be normal in intensity. In those who have left ventricular failure, obviously you will have a left ventricular third heart sound. Ejection click would mean it is valvular stenosis. Ejection systolic murmur is heard in the second right and third left intercostal space, and delayed peaking would suggest severe stenosis. The peaking, the more delayed it is, the more severe stenosis it is. Of course, if there is calcification or fibrosis, which is rarely seen in our practice, it is more often seen in elderly and those who are in 30s and 40s, then A2 component is going to be diminished. In fact, if there is calcific aortic valve, even the click may disappear. Aortic click may disappear. ECG, as expected, can show left ventricular hypertrophy with a normal QRS axis. Again, I would like to point out that left axis deviation does not go with left ventricular hypertrophy, unlike pulmonary stenosis where you have right axis deviation and right ventricular hypertrophy. You can have left ventricular strain pattern if there is severe aortic stenosis, but what I want you to understand is that a normal ECG can occur in severe AS also. So normal ECG does not rule out severe AS. Normal ECG rules out severe PS, but normal ECG does not rule out severe aortic stenosis. Of course, if you are getting LVH, especially strain, then it has to be severe aortic stenosis. X-ray chest going to show you normal sized heart, dilated ascending aorta because of postnodal dilatation. But in case of bicuspid aortic valve, it may be also contributed by aortopathy, which is often associated with bicuspid aortic valve. And it may be there even without aortic stenosis. You may have a dilated aorta because of aortopathy. Of course, if there is cardiomegaly, if there is ventricular failure, that will show you cardiomegaly as seen over here. This is an adult, I mean not adult, really an older child who's 16-year-old who came with severe LV dysfunction because of severe aortic stenosis. Again, here you don't go so much by gradient because your gradients are going to be wrong when there is severe left ventricular dysfunction. So if you have an AS and if there is cardiomegaly, think about ventricular dysfunction. And again, when you are thinking about ventricular dysfunction, you need to have an urgent intervention done, whatever the gradients are. Echocardiography, very useful. It will tell you the site of obstruction. It will tell you the severity of obstruction. It will also give you the exact gradients. And here in case of aortic stenosis, we also look at not just the peak gradient, but mean gradients, which are likely to be more accurate. And of course, it will also tell you how is the ventricle. It would be hypertrophic, but if it is functioning normally or not. This is usually the way we classify. Obviously, these gradients are being talked about when the left ventricular function is normal. So anything which has a mean gradient of more than 40 is considered severe aortic stenosis. Here is an example of Doppler gradient being measured in case of severe AS, and as you can see, you need to measure not only the peak gradient but also the mean gradient, which is usually done by tracing, by continuously tracing this Doppler signal. And you can see the mean gradient is 49, peak gradient is 90, and that obviously falls into severe aortic stenosis group. Subvalvular stenosis can be differentiated by absence of click. Ejection systolic murmur will be a little lower down. Again, it may appear like that of a VSD. There will not be post-stenotic dilatation of ascending aorta, and you may have associated murmur of aortic regurgitation. As I said, this could be because of a membrane called subaortic membrane. It could be because of a muscular narrowing. And in both cases, because of the jet striking the aortic valve, often these patients have associated aortic regurgitation, which, if significant, may be audible clinically. Supravalvular AS, on the other hand, is rather rare in isolation. It is often associated with Williams syndrome, where you may also have peripheral pulmonary artery branch stenosis besides extracardiac abnormalities. Again, there will not be a click. Loud A2 will be loud because A2 is in the high pressure circuit. And because of the jet effect going into the right subclavian, you may have a difference in the pressures in the two arms. That means right arm pressure may be higher than that of left by more than 10 millimeters of mercury. Up to 10 can be normal, but more than 10 difference would suggest that you may be dealing with supravalvular aortic stenosis. Of course, murmur is going to be little higher, sometimes heard over the back. How do you treat aortic stenosis? Again, if you're talking about mild to moderate valvular stenosis, we can follow them up. We can periodically call them for ECGs and echoes. But if it is severe, that means peak gradient, mean gradient being more than 40, you should go for a balloon dilatation. Sometimes even for moderate AS, we go for balloon dilatation as long as if the patient is symptomatic. The procedure, balloon dilatation procedure, is done in the cath lab. It has a good success rate, but you may end up developing some aortic regurgitation. And remember, this is a palliative procedure. Unlike pulmonary stenosis, where you do balloon and patient is almost done with, you don't need to worry too much. In case of aortic stenosis, invariably, it results in either restenosis or progressive aortic regurgitation. And ultimately, majority of these patients will end up replacing their valve at some point in life. But the idea is to postpone that as far as possible. Of course, those who with subvalvular or supravalvular do not respond well to balloon, and they are best treated with surgery if the obstruction is significant or if there is aortic regurgitation. If you're not ballooning them, if you're not treating them, I think those with severe AS must refrain from strenuous exercise and competitive sports. And that kind of an advice needs to be given to them when you're seeing them in the outpatient department. Again, we had written it up in Indian Pediatrics Journal in 2019 that what are the indications. Again, you would require immediate intervention for newborns with severe AS who are duct dependent. And those who have left ventricular dysfunction, regardless of the valve gradient. So when we are talking of valve gradient, we are obviously talking of valve gradients with normal ventricular function. If you have ventricular dysfunction, the gradient is only 30 or 35. That would also stenosis, because gradients are underestimated when there is ventricular dysfunction because of low output. If it is a relatively stable child, then as I said, mean gradient of more than 40 is an indication for balloon dilatation. And if patient has symptoms, then even less gradient you may want to treat with balloon dilatation. If you're not sure about the symptoms, whether it is because of AS or not, and the gradients are coming in the range of mild or moderate, you can actually put them on exercise treadmill and see what happens to their symptoms, what happens to the ECG, what happens to the blood pressure response. And that can give you an idea whether the symptoms are genuinely because of aortic stenosis. It's also important to understand that aortic valve balloon dilatation is not such a simple procedure. It may result in aortic regurgitation, and we know it's a palliative procedure. Therefore, don't do it in children in whom it is not indicated. So if there's an asymptomatic child with normal ECG and normal X-ray, AS gradient is less than 40 mean, it is best not to intervene, just follow them up. Again, if there is already regurgitation, aortic regurgitation of more than mild, it is better not to balloon them, because they are probably going to end up with more severe aortic regurgitation and may need replacement of the valve rather early. So we also need to understand that you should not intervene if it is not indicated, because it is not a curative procedure. It is a palliative procedure associated with a finite level of morbidity of the procedure. So I'll pause here again and would ask for any questions and, of course, comments from the panelists.
Again, there's a question in the chat box regarding how to manage neonatal aortic stenosis before getting a definitive cardiac intervention. So how
to evaluate
a suspect and then manage with first, and then refer to definitive cardiac evaluation.
Right. So I think if you have any newborn who has a murmur, remember aortic stenosis, pulmonary stenosis can produce systolic murmur on day 1 of life, because these are obstructive lesions, unlike a VSG or a PDA where the murmurs may come later. So if you have murmur on day 1 of life, it could be AS, it could be PS, it could be tetralogy also, of course, depending on the other findings. If you have murmur and your ECG is showing right ventricular hypertrophy, right exacerbation, remember it can still be severe AS. And I don't know if I missed that ECG. I just wanted to see, this is okay. This is an ECG of left ventricular hypertrophy, but I don't know. I should have shown you one ECG where I want you to understand that newborns need not show left ventricular hypertrophy. In fact, newborns often show right ventricular hypertrophy, even in aortic stenosis. Yes, and that is something which is very important to understand for those who are dealing with newborns and neonates. Don't expect left ventricular hypertrophy in a newborn. In fact, if the left ventricle is under too much of stress, then you're likely to get right ventricular hypertrophy and right axis deviation in newborns, simply because everything is getting decompressed through the patent foramen ovale. So even if there is a high left ventricular pressures, it is producing high left atrial pressure, and it's going to go through the patent foramen ovale into the right atrium, and therefore result in right axis deviation and right ventricular hypertrophy. So that is important to understand. So of course, murmur, presence of ventricular hypertrophy, if you have cardiomegaly on the X-ray, that can also help you. And of course, echocardiography will also show you not just the gradient. I always, tell our students to look at the valve morphology. It is not a good idea to just put a color as soon as you see 2D. Look at the 2D, look at the way the aortic valve is opening or not opening well. Sometimes the gradients may be very low, 20, 25, 30, but you can see that the valve is not opening well. You have a hugely dilated right atrium and right ventricle. You have a rather smallish mitral valve, smallish left ventricle. So all those would suggest severe aortic stenosis. And of course, if there's a ductus-dependent condition, like you're having right to left flow into the ascending aorta, you have a fuel flow in the ascending aorta, which is, instead of going from LV to aorta, it is going back from the arch of the aorta into the ascending aorta. Those are all features that it is a ductus dependent circulation. And those are the conditions, those are the newborns who need rather urgent. On the other hand, if you have a relatively stable newborn who's having a murmur and an echo has come with a gradient of 30, 35, even 40, I would just not worry too much at that stage. Yes, we need to have a very close follow-up, but they can quickly worsen. Therefore, they require a close follow-up, and the left ventricular function needs to be assessed every time. Right atrium and right ventricular size needs to be assessed at every time. But if they're stable, if the left ventricular function is normal, if the right atrium, right ventricle not dilated, then you can follow these patients up.
And critical, just one comment, ma'am, critical aortic stenosis, which is being, they ask here, so they present with the sort of shock. So any newborn deteriorating in the third, fourth day of life with poor pulses and all, just start on prostaglandin, because it could be gut-dependent aortic stenosis, coarctation, interruption, so this type of the lesion. So better to keep on doing your neonatal management, stabilize them, and start prostaglandin. If echo is available, it is great. If it is not, so better to get a plan to get an early echo from a place where pediatric cardiologist is there. So that is the thing where intervention can be done. Yeah. So any sick newborn, any suspicion of heart defect, so where you are like in mind, he's in shock, and also prostaglandin without, like, you don't need echo to start prostaglandin. So can be started and stabilize the baby, and then take your time for the further things.
Absolutely. In fact, some of these severe ACE patients may not even have good murmurs because of such a low cardiac output, and therefore having a murmur is not necessary. Although I said there should be ejection systolic murmur, but in case of newborns, you may not have any murmurs. So I think you are absolutely right. They just come with a kind of a collapse. State. Yeah, absolutely.
So one other question on the chat box was that if there is got a asymptomatic patient with the bicuspid aortic valve, how to follow up?
So I would just, if the gradients are low, like less than 25 or something, ascending aorta is not too dilated, I would just follow them up every 2 years. If it's, of course, an older child. If it is a younger child, I will call them every few months, 2 or 3 months. But once they've reached an age of 1 year or so, I would follow them up every year. And then once they have reached a stage of 8 or 10, I will follow them up every 2 years, as long as gradients are less than 25 and the aorta is not dilated, because we have to look at both the things, not just the gradient, but also aortopathy.
Yeah, and they require lifelong follow-up. Any bicuspid aortic valve, whether it is stenosed or recurrent or both or none, but they require lifelong follow-up. That thing should be told to the family, that be in touch with the cardiologist.
In fact, now we say that not only their siblings should also be followed.
Yes, ji ma'am.
Because I think bicuspid aortic valve is rather common, and generally bicuspid aortic valve is not an issue by itself, but it is the aortopathy which really is a cause of concern for these patients.
So, like, even very small baby, small infant, they come a +5 Z-score of aorta, very scary, and some are just mildly dilated. Right. And in fetal echo, when we find some sort of discrepancy in aorta, then obviously we keep a suspicion that it is probably bicuspid aortic valve, and we follow them closely and in neonatal echo. So things start from the fetal echo is also very important.
Right.
A few more questions are there, I think.
Ma'am, there are no more further questions.
Okay.
Mm-hmm.
Okay, so the last lesion that we're going to discuss in this is coarctation of, I think we still have some time, no? Yeah, okay. Coarctation of aorta. And I think it is something that you are very well aware of. There is an obstruction outside the heart in the aorta, just after the left subclavian artery has taken an origin, which is basically the junction of arch with the descending thoracic aorta. Often it is distal, often it is distal to ductus, but in some newborns it could be proximal to the ductus. And left subclavian artery comes usually proximal, but you can have involvement of the left subclavian artery within the coarct segment. And you can even have right subclavian artery, which is anomalous, which is arising beyond the coarct segment. Bicuspid aortic valve association is rather common, and rare complications, I would say rare complications would include dissection of aorta and rupture of baryoaneurysms within the brain, because there is so much hypertension in the upper limb in these children that they develop baryoaneurysms within the brain. Now, as expected, during fetal life, they're not at all any issue, because normally also the blood supply to descending aorta is from pulmonary artery through a patent ductus arteriosus. But neonates who have severe obstruction, and once their ductus closes, they also present as in a state of shock. And as Dr. Munesh said, that when you are in doubt, go ahead and start prostaglandins, because it could be critical AS, it can be severe coarctation. If it's a relatively older child, you expect upper body hypertension, but unfortunately, we often don't measure blood pressure in children, and therefore we tend to miss it. But if you're carefully looking at the femoral artery or femoral pulses, then you are going to diagnose it, because femoral pulses are going to be weak and delayed. Collateral arteries develop much later, and therefore to expect continuous murmurs over the back is something that you're going to see only in older children. Adults, very rarely you're going to feel them, or you're going to hear those murmurs in neonates and young infants. As expected, left ventricular pressure is going to rise and trying to take care of that obstruction, and that results in left ventricular hypertrophy. And left ventricular failure is rather unusual in coarctation of aorta, except in neonatal period or early infantile period, and in elderly patients, or I would say middle age, that is 40 years and above. So left ventricular failure is not a feature of coarctation of aorta, even in cases of severe coarctation, because you have collaterals developing which decompress the upper aorta and therefore helps them to grow. But yes, neonates can present with collapse, neonates can present with left ventricular failure. So newborns and infants may present with failure, as I said, but older children tend to be totally asymptomatic. And if you're not keen, not careful enough to check their blood pressure or feel their femoral pulses, then you're going to miss this diagnosis. I think pain and weakness of the legs are very rare symptoms, but dyspnea on exertion is something that you may get, especially because of hypertension in the upper limb. Hallmark of diagnosis: weak and delayed femoral pulses and other lower limb pulses, and variable degree of hypertension. Now, as I said, it is easy to miss because we don't record blood pressure and femorals are not palpated routinely, but it is also easy to miss in newborns, even if you've done an echocardiogram, even if you've examined the baby, felt for the femoral pulses, simply because there's a large PDA which is open and which allows the femoral pulses to be felt almost normally. But once the ductus closes, then coarct actually appears. And that is the time when they actually can collapse because of severe hypertension in the upper limb and left ventricular failure. So clinical features: good aortic pulsations in the suprasternal node, something that you should not be feeling in children. A2 component of second heart sound is accentuated, like in hypertension. Ejection click will be present if there is an associated bicuspid aortic valve. Murmur due to coarctation is usually unusual. It is often a late ejection systolic murmur. Sometimes it can be continuous murmur, which will be heard over the back. For the collateral, because of the collaterals, and even the coact itself can give you a continuous murmur if it is tight, simply because the blood is taking very long time to go from upper part of the aorta into the lower part of the aorta. ECG will show again left ventricular hypertrophy, normal QRS axis, but it can be normal. Left ventricular strain pattern will indicate associated aortic stenosis. So remember, coarctation of aorta, even if it is severe, does not usually produce left ventricular strain. If it is present, it is perhaps because of aortic stenosis. And again, as for aortic stenosis, in newborns, you may have right ventricular hypertrophy, right axis deviation, simply because whatever is happening on the left side is being reflected onto the right side through the patent foramen ovale or through a small AST. X-ray test again will be normal sized heart. You may be able to see in an over-penetrated film like a 3 sign, as we call it, which is site of obstruction. Barium swallow, if you do, you will see the typical E sign. Of course, we don't do it anymore. And I think another thing that you have to look for in older children is the presence of rib notching, which if present would be quite diagnostic of coarctation of aorta. I think with the advent of echocardiography, it is very easy to diagnose coarctation of aorta if you have a high index of suspicion, because it tells you the anatomy, it tells you the severity, it also tells you associated bicuspid aortic valve or other lesions. And you can actually get the gradient if you do suprasternal view. And it is not just the peak velocity that one should think of, one should take it, but this is the peak velocity. But what is hallmark, or what the hallmark of aortic of coarctation is this continuity of the signal. See, there is no touching the baseline. Even in diastole, it is much below the baseline, and the next systole starts. So this continuous signal, as we call it, or a drag, as we call it, is quite suggestive of coarctation. And if it is really, continuous throughout in systole and diastole, it indicates severe coarctation of aorta, even if the gradients are 30 or 40. So uh, besides this picture, as I showed you here of echo, in many older patients or adults, you may not get such good pictures. You may end up doing investigation like CT MRI, not only to make the diagnosis, but also to see how big the ascending aorta is, what is the size of the isthmus, how tight the coarct is, because these are the information you need for planning management, especially when we are dealing with older children. In newborns and in infants, it's easily diagnosed, but in older children, adults, you may require more imaging to get the entire anatomy of the coarct region. So just simple diagnosis of coarctation is an indication for its treatment, because you will only diagnose when the gradients are significant. And as was told for aortic stenosis, keep prostaglandin infusions ready, because in newborns coming with collapse, as the ductus closes, you may have to use prostaglandin to keep the ductus open before the patient can be taken up for surgery. Older children who are hypertensive, you have to start antihypertensive medications. Again, in older children and adults, balloon dilatation is the procedure of choice. However, when we are talking of neonates and infants, especially under 3 to 6 months, it is perhaps better to go for surgical relief, because surgical relief will have less restenosis rates compared to balloon dilatation. Although both have restenosis rates, but surgery is superior than balloon dilatation. In older children and adults who are, let's say, more than 20-25 kilos of weight, we also try and do stenting of the coarct segment, endovascular stenting, to avoid restenosis and to abolish the gradients altogether. So these are basically class 1 indication, which I have already told you, but basically I just want you to see this particular child where a balloon dilatation has been done, and you can see that it's a relatively easy procedure. But when it comes to older children, adults, then it is better to have an endovascular stent. And you can see this metal tube over here, because it will reduce the gradient, it will reduce the chances of restenosis. And that's why you can do it in older children. In small children, you don't want to do it because it has a specific size. So if you put a smaller size in small child, then it is not going to grow. And therefore, we avoid stents in small children. We only do it in older children and adults. So coming back to the case at the end of the lecture, I think the diagnosis is quite obvious, since there is a click, since the A2 is normal, since the second heart sound is narrow split, it is a diagnosis of severe valvular stenosis. Why severe? Because patient has typical dyspnea and angina on exertion, so it has to be severe. You will confirm the diagnosis by echocardiography, but irrespective of what you get on echo, if it is aortic stenosis, whatever the gradients are, it is best to send this patient for aortic valve balloon dilatation, because he is symptomatic with dyspnea and angina on exertion. So I'm going to stop here. I'm happy to take questions and comments.
Thank you, ma'am. Thank you. Means the outflow tract obstruction is it's targeted to the pediatric resident. It's like it will be really grateful for them to have this presentation with them. Ma'am, what will be the follow-up? Like coarctation of aorta, aortic stenosis means obviously we have to. What should be our plan for the coarctation of aorta isolated if it is not severe? What should be the plan of follow-up for the treating physician?
You mean without intervention?
Yes.
Or after intervention?
Without intervention, so, mild coarctation of aorta, or I mean, how to follow that. One is newborn period and the older kids. Sometimes they just come for routine checkup. We find this type of mild narrowing, which is not the diastole is not, the spill is not there.
Right.
But there is of around 15-20 sort of no significant difference. So can we leave them from the follow-up, or we should continue them? Obviously,
I think if the ductus has closed, then you can leave them for follow, because in case of ductus arteriosus, you're always worried that, this coarct may show up when the ductus closes. So I think that is a patient where you will have to keep a very close follow-up in a newborn, in a neonate. If the ductus has closed and you are still getting mild coarct, gradient of 15, no diastolic drag, lower limb pulses are well palpable, there is no upper limb hypertension, I would just leave them alone.
The chances of developing into significant coact?
Very low. Very low. In fact, I have had a lot of patients whom, when we, used to screen newborns, we had a lot of patients who would show you 15 gradient, 20 gradient, no diastolic spill, ductus closed. Generally, they have done reasonably well. In fact, I think if I remember, I have a patient who is now about 11, where
Yes.
11 or 12, where we diagnosed, we kind of thought about coact right in the beginning. In fact, till about 2.5 years, I always said that there is mild coact, but we will follow up because the upper limb pressures are normal. Left ventricle is normal. But then now I don't see any coact at all. So I think some of these so-called mild coact are probably going to grow as the child grows. The coact region also grows with the child, and the gradients tend to disappear. But yes, we need to be very careful in newborns, and I think up to 1.5 years, you could always not predict what's going to happen to them.
Yeah, like it's like isolated when we do neonatal echo, sometime 2 weeks, 3 weeks of age, there is some peripheral PS. Sometimes we have this mild arch gradient. So peripheral PS, obviously we know this is transient and will go by the 2-3 month of age. Coarctation, when there is some coarct gradient, arch gradient, then we are sort of worried. But if no other associated feature like bicuspid aortic valve or other issues, then obviously I think. I am following many babies now, like as you said, ma'am, that 11-year-old, few years old now, then this 15-20 gradient came to 8, 7, 6. Now there's just no turbulence in arch area. So it's something probably related to ductal closure when we see in the early neonatal period, and then but it is better to keep a watch for at least till infancy, 1 year of age.
I agree. I think till about a year we need to be careful. And when we say gradient of 8 or 9, as you just said, I think what we are not measuring is the gradient proximal to the so-called coact and the distal. Ideally, you should have V1 and V2. That means you should have a velocity around here, and you should have a velocity here. And if you're getting gradient of 8 or 9 here, maybe your proximal velocity is 3 or 4. And in that case, your gradient is actually 5. So in case of coarctation, we are not really measuring V1. We are only measuring V2. That's number one. And number two, if you have a good bolus of the blood on color Doppler, if you have no spilling into diastole, I would probably just keep them on follow-up.
And post-intervention, whether it is balloon or surgery, the physician, because they all are in follow-up with their treating primary pediatrician or general physician. So what thing they should keep in their mind, especially for the coarctation of aorta?
So in older, in children, let's say 1 year, 2 year, 3 year, or even older, I would ask them to always check the blood pressure in the upper limb and also possibly in the lower limb. In fact, some of my patients have bought their BP instrument with different cuffs. And I tell them, if you don't have the right cuff, please take it in the leg. But do check blood pressure in the lower limb also. And of course, if there is no upper limb hypertension, you can probably relax. But if there is mild upper limb hypertension, better to check the pressure in the lower limb also. So look at the gradient. I think the gradient is very well reflected by the upper lower limb pressure difference.
Yes.
Provided, of course, we are not talking of coact with a lot of collaterals. We are talking of a post-intervention where hopefully we have done a good job and opened the coarctation. There, the gradient between upper limb and lower limb is quite suggestive of obstruction or present or not. So I would tell them to look for blood pressure. And we know that even after successful opening of coarctation, if you've done it little later in life, blood pressure may continue to be high. A lot of my patients are on beta blockers for that reason. And of course, with the aortopathy also, they require beta blockers. So following intervention, upper limb pressures must be taken regularly by the physician who is following them. And of course, if there's any concern about the lower limbs being weaker, then of course they need an echo.
And even if we intervene on time, like infant, a particular percentage of kids may develop hypertension later in life. So it is not that it is ideally do on time, and chances are lesser, but still they may residual hypertension or may develop later hypertension. So blood pressure is a very important test. Whether it is coarct or non-coarct, I think every pediatrician should be sensitive to check blood pressure if they have some cardiac intervention, especially coarctation, or in isolation also. BP should be checked in pediatric OPD, which is an investigation. It's not very regularly done. So we have to be very sensitive about the numbers, heart rate, saturation, and blood pressure. So BP should be there in OPDs.
Yeah, I agree. I think we all need to have the right cuff also for these patients. And many a times the excuse given is that they did not have the right cuff for measuring blood pressure. I think it's part of our examination that we
Yes,
should have a right.
and it is
If we
our
can,
job to get.
yeah, if we can have an oximeter in everybody's pocket, I think we should also have the right cuff.
There's another question about the medical management of the obstructive lesions. So, is
So,
there any role? And
I think there is absolutely no role of medical management in AS and PS, because you are going to intervene if it is severe. If it is mild or moderate, nothing needs to be done, just a follow-up. As far as coact is concerned, I think there is good amount of medical management role. Firstly, for treating hypertension, for which you can use beta blockers, you can use, if necessary, even diuretics, but also for bicuspid aortic valve and aortopathy, whether associated with AS or not, you will have to give them some drug to at least reduce the progress of aortopathy, and that could be a beta blocker or even an ARB like losartan.
ma'am, any role of the statins in bicuspid aortic valve? Because
I think there's a lot of talk about it, but we really in at least in children we have no role. In elderly, there is talk about statins which will reduce the, or at least reduce the progression of aortic stenosis, but not in children and young adults.
yes. Saad, any comment from your side? Any question from your side?
Yes, ma'am. Again, ma'am, it's, nothing has to be said about ma'am. Such a good presentation and very, ma'am, in the way she teaches. So it's very helpful for all the students who are there, especially the postgraduates who are listening to it. Basically, these obstructive lesions are always, they can have a very critical presentation or remain, you can have both the spectrum, remain relatively asymptomatic. So they're very extreme presentations. So one of the important is the coarctation. We actually at times miss also, and most of the, even we start suspecting coarctation in any left to right shunt, which is especially a VSD, which is presenting very early to us, because they can have associated coarctation. So another thank you, ma'am, for such a good.
I think Shad, you brought a very good point that in patients, I mean, I did not really take any association. I took just isolated, but in patients of VST, not only PDA, in patients of VST also, you may underestimate coarctation simply because there is less blood going across the, the aortic valve and more going into the pulmonary artery. So you can, and therefore I think it's an important point that you bring about, that in patients with large VSTs, we should not just go by gradients. We should also look at the 2D picture of arch, and they may have hypoplasia of the arch, they may have mild coarctation, which can actually manifest later once you have closed the VST.
Yes, ma'am.
Yeah, especially it's a problem in newborns and neonates.
Yeah. And shunt lesion presenting early, we should be, means as a echocardiographer, we should be very careful not to miss the. Yesterday only I saw a case with large VSD for 4 weeks, but a quark is very distal, very distal. Means it is very easy to miss actually, because proximal arch are very well seen, but the presentation was very unusual, sort of from the third, fourth day of life.
Right.
So you have to search for the lesions actually. It's
yeah, I agree. I think I had a patient where we did a PA band and then the arch showed up, the echo arc showed up after that. So I think these are newborns have a very sort of circulation which changes day to day.
Yes.
So one has to be very careful. Yeah, agreed.
So thank you, ma'am. Thank you, ma'am. Great presentation, and it's lucky that now the residents have the luxury of getting these presentations online and sitting at home, and it will be shared with all of them. So it's really luxury in today's world that we can interact, we can get the inputs from anywhere sitting. So this COVID, it was a bad days, but obviously we could connect online because of COVID. I really feel it's everything come with some blessings.
Yes. Silver lining.
And, yes. So thank you, ma'am. Thank you, Saad, and thank you, IPUP, for giving us the platform to connect with our residents all over Uttar Pradesh. And thank you all. Thank you all for joining. Thank you, ma'am.
Thank you.
Thank you.
Thanks.